Right, we've got some questions coming in on the old iPhones and whatever via the app, so I'm going to go through those first of all, if I may. I've got a number, and here's one really, I think it's possibly for you, Angel, but for you and Terry as well, and that's the question about the risks of NSAID use for 2 to 3 days, once or twice a month, for treatment of ongoing frequent headache. Is that different from single use? Or very much different?
Well,
you have to press the button and the light comes up. Yep.
Well, do you want to answer that?
You answer now. I'll give it my view.
Okay, so first of all, we don't have that information. So then, we cannot answer properly to this question. But this is clear that what we know is that especially in healthy people, in patients without any kind of serious risk factors, such as, for example, a previous ulcer history, the toxicity of this compound disappears rapidly after you stop taking the compound. So then, very probably, if you take only as once a month this compound for 1 or 2 days, I think that the risk is pretty much the same. So I think the real care should be put on patients with risk factors, because then in that situation, especially even if they have a previous peptic ulcer, I think that even short-term use could induce a bleeding, because we will never be sure that this patient has an asymptomatic ulcer. And if you take, for example, aspirin, then you may induce a bleeding because of the antiplatelet effect.
I think the question...
Press the button again.
I think the question's been answered very much from a toxicology point of view, from a practice point of view, and certainly the risk of developing chronic daily headache. It would be a concern if that was increasing any more than that. Certainly someone on a codeine preparation on 13 days out of a month, you would be looking at possibly a definition of chronic daily headache. That'll be higher for paracetamol alone or indeed ibuprofen, but they will contribute to that as well. So I think that's the concern, where you're using it more frequently than has been suggested, but that may develop, and it's important that people realize that when they're using these preparations, so appropriate use would avoid that.
Terry, maybe I can ask you a question here. You know, I know Belfast a little. It's a city I like very much. Very good food there, as I recall. Some very, very good restaurants. But for your practices, because I know you've got 2, and where they are, do you have a fairly stable population? Do you know the people coming in? Do you have relationships with them? So you'd be able to track that sort of behavior by and large, would you?
You can certainly track the behaviour in terms of, I suppose I don't want to overemphasize the problems associated with chronic daily headache. I think the bigger problem is codeine misuse, and that's something that we are constantly battling, not only in Belfast but in every other UK region. So it's something that has to be dealt with. And I think one of the questions are going to be, why do I object to codeine? I certainly don't object to codeine. I think codeine is an extremely good drug when used properly. But we have a population in Northern Ireland of 1.8 million. And in the annual consumption of codeine in one preparation, that's paracetamol 530 milligram, is 1.6 tons, which is massive. And the question is, you know, why are we using such a high? That would be appropriate to transfer those patients onto morphine sulfate, you know, long acting. So from the point of view of OTC codeine, I don't believe it adds a significant analgesic benefit that justifies its use.
But that combination of paracetamol and codeine...
OTC.
That's OTC still, is it?
No, OTC is 8 milligrams.
It's 8 milligrams, yeah.
And that, I think the evidence suggests it's not effective as an analgesic.
Yeah, okay. And another question we've had in about saying that codeine is a problem in Australia. OTC codeine problems are problem in Australia. But that's something I think, generally speaking, wherever we've got OTC codeine products available, we're concerned about it, aren't we? Because it's to do with that general increase in opioids which are coming from, perhaps, if I might put it like that, overprescription by doctors, as well as diversion of prescribed medicines and use of opioids that might be available OTC.
Yeah, I think you're absolutely right. I think the problem isn't created by the OTC market. The problem is created by the fact that access to codeine-containing products on the OTC market appears to be easier than it would be in secondary care or in tertiary care. So I think that's the way it's working, is the accessibility. Then pharmacy is left with the policing role, which I think is unsatisfactory to a degree. And I just wonder, Greece, for example, I understand, do not have an OTC codeine version. Is that a major problem for the treatment of minor conditions? I don't think so.
Okay. Another question that's come up here, which maybe Angel you can look at. How long must NSAIDs be taken before their use is considered chronic?
Well, I think that this is there is no a clear definition. You know, I can just in our textbook we have the definition of what is acute diarrhea, chronic diarrhea, but not chronic acute use of this compound. So I understand for acute use, you know, anything be taken just for up to 7 days.
Yeah.
You know, anyone taking this compound beyond a week, 2 weeks, 3 weeks, I think that then it's entering the field of chronic use, and then the risks are different. So everything that yes I reported here and put the evidence is for short term.
Yeah.
Okay, it's different. So anyone taking, and this is an important issue. This is an important issue because I think that there is a small subset of people who just get OTC compounds, but they use it chronically.
Okay.
So then, for them, we could say that the risk cardiovascular and GI is present, although we know that low dose is different to high dose. But even low dose taken in a chronic way, you know, carry GI and cardiovascular risk.
I know you're there. Thank you very much. I've got a couple of quick questions I can deal with really quite easily here. One of them is the question for tension headache and migraine. Why don't we report efficacy on aspirin, caffeine and paracetamol combinations? For Thomas, who asked the question, I apologize. That just happens to be one of the reviews we've not done. We did look at it some years ago, couldn't find much evidence. There is more now, and if I were to look at Sheena, she is nodding and holding up a thumb and saying, yeah, it's on the program to do quite soon. There's also a couple of questions here about diperone, and I can tell you that diperone is on our analgesic efficacy list because we know that it's used in many parts of the world. There's not a huge amount of data for diperone, but there is some data there. Then I'm asked about taking NSAIDs with food, or taking analgesics with food. This is actually quite an interesting area. And in Oxford, we've published some work on this in recent months. The simple fact of the matter is, I think when it, and I've not had time to expand on this too much, but when it comes to these acute analgesics use, what we're able to say is that the speed at which the analgesic gets in and that peak plasma concentration are related to, first of all, and fairly obviously, the speed of onset, secondly, to better overall analgesia, and interestingly as well, to longer duration analgesia. And that seems to be pretty much of a constant. When you take your analgesics with food, what happens is you approximately half the peak plasma concentration, and it occurs several hours later. And so one's reducing the efficacy dramatically. And that means you have to take more analgesic to get any effect whatsoever. This is a very bad thing to do because it means that you're increasing largely the amounts that you take in. And actually, you know, when you're looking at fast-acting ibuprofen, for example, 200 milligrams of fast-acting ibuprofen is as good as 400 milligrams of the standard. If we're able to get that amount of efficacy with half the dose, then I'm willing to bet that even Angel Lanas will agree with me that that is a good thing. Yeah, good. Okay, I've tackled a few others. Would you like to ask your question, sir? And tell us who you are and where you're from. I'm not hearing you.
Okay, thank you. Yes, I'm Eyal Melamed from Israel, and thank you for the interesting session. So there are many companies that manufacture these OTCs. Are they all the same? Which one should we buy the cheapest? And another question in the same theme is, if we buy through the internet, maybe OTCs that are manufactured in the third world, are they safe? Which one should we buy?
Do you want to take that, Terry?
Yeah. First of all, the internet is presenting a huge challenge to ensure the safety and efficacy and quality of medicines. And we have documented very many instances, not only in the OTC analgesic area, but purchasing of medicines which in actual fact turn out not to be what the person bought. So there's still a piece of work to be done to assure the quality of medicines secured over the net. At the current time, we haven't got that. And certainly taking medicines which coming from a different jurisdiction, I would be advising against it. But then you would say a pharmacist would say that. Fundamental must be the quality. And the quality is assured by the pharmaceutical companies in Europe, who are regulated by the authorities which regulate to an extremely high standard. So that will answer that question. In terms of, there therefore would be no evidence to suggest that brands versus OTC generics of the same type of medicines should be any different. But there are formulations, and Andrew has mentioned that in terms of, for example, different types of salts, where you will get increased deliverance of the drug, which in actual fact would reduce the need for more. So there are benefits from certain categories of OTC medicines which are branded. Yeah.
Okay. I've got a question here on, which has got 5 likes, so it's one I've got to ask. It says, due to the increased risk, I'm assuming here it says related to celecoxib, I'm not quite sure what that means, would it be safer to use naproxen instead in terms of long-term use for elderly people with OA-related pain? Would you like to comment on that, Angel?
Sorry, I don't know whether it did understand.
Well, I'm not quite sure what it means, but
no,
should naproxen in long-term use be our go-to medicine because it's got a lower cardiovascular risk than all these other drugs? Yes or no?
Well, in principle, yes, for the cardiovascular, but not for the GI. So you need to balance. You know, the question was on chronic use.
Yes.
So then, in chronic use, then you need to consider other factors, different to what we just commented here. You need to consider the risk factors. So it depends on why this patient is taking in a chronic way naproxen or why he's taking celecoxib. If the GI risk factors overcome clearly the potential of cardiovascular, then celecoxib should be the right choice. But if the cardiovascular risk factor overcome clearly the GI, then naproxen could be the right choice. But in that situation, depending on the risk factor, then a PPI should be added. So that's, it's a different issue that we are just discussing here. And we will have to wait to the Scott trial that was presented last days in London, suggesting, the Scott trial suggesting that, as you just sent to me the abstract, that the cardiovascular event rate was very low, much lower than it was expected, even for the very elderly, and no differences between celecoxib and the other NSAIDs. But we have to wait to see all the results properly.
Did you want to comment there, Terry? You were getting very agitated.
I was agitated.
No, you need to press it.
So I was agitated mainly because of again, the complexity that we get into. We're differentiating between acute use, which is OTC, and chronic use. And Angel's absolutely right. If you're using chronic use, naproxen is the safest, but you need to add in a PPI, and that's current practice in the UK, and that's what sort of is guidelines to GPs, and it seems to be sensible. There's also a range of myths that exist around some of the OTC preparations, and we've discussed those. And those myths are very powerful in the sense people see NSAIDs as NSAIDs. What isn't clear, and we've just talked about that in the context of celebroxid and naproxen, but ibuprofen, for example, is a very different NSAID in terms of its adverse event profile compared to the others. And that is poorly understood by general practitioners, it's poorly understood by pharmacists, and it's been reinforced by the regulators who identify these things as once they're in SPCs, they're extremely difficult to get out. And the other area that certainly pharmacy is restricting access to ibuprofen in particular is the area of respiratory conditions, whereas the evidence suggests it's extremely rare that that would be a problem, but you'll find that most pharmacists believe ibuprofen cannot be used in asthma, which is completely incorrect.
Yes. One quick question.
A couple of questions, but it sounds like all these medications are very safe, basically for 1 or 2 days, maybe no more risky than a couple of beers or a couple of wines a day. But would the safety be enhanced if the packets were limited to 12 to 20 of it, whatever preparation it is, so a smaller supply?
The UK have restricted them certainly to pack size. OTC general sales is smaller than pharmacy-based, and pharmacy is restricted to 32. And I think that that has certainly been a part of a management process. You don't really need more than 3 to 4 days supply for certain conditions, and that I think is appropriate, and it is a safety issue, and it does work.
And restriction on pack sizes of paracetamol in the UK had a major effect on reducing overdoses. A couple of quick ones. Anybody want to comment here on the combination use of aspirin and paracetamol? I suppose it depends on the dose to some extent, doesn't it? And you can get aspirin, paracetamol, caffeine, as we said earlier on, as a combo. But anything particular one wants to say about it?
At least from my point of view of safety, no concern.
No. Does anybody want to say anything about a mechanism of action of paracetamol via the anandamide system? I have no idea. Have you got any ideas?
I think it's probably safer to stick to the fact that we don't know how paracetamol works.
And maybe it didn't work very well anyway for most circumstances.
COX-3 never has been just discovered properly.
And the final question I've got here, unless there's any new ones coming up, is one I'm not quite sure of. And is the toxicity of tramadol and paracetamol decreased in the synergistically acting combination product Zaldiar, which is 37.5 milligrams of tramadol and 300 milligrams of paracetamol? I personally couldn't imagine a single reason why it should be. Certainly not on formulation, not on toxicity. Okay, we're right out of time, ladies and gentlemen. Can I just say thank you very much to Terry and Angel for being here and giving us the benefit of their insights in OTC analgesics, and actually for you coming here, and particularly to our friends at EFIC for allowing us to have a workshop all about OTC analgesics, which, I don't know, might happen in pharmacy conferences. I've never seen one in a pain conference. So I think we've all been privileged to be at a world first. Thank you very much indeed. Bye-bye.